Very good morning. Hi, I am Dr. Janak Patel. Today I'll be talking on what we call as extrasystole. Already we have given a little idea regarding extrasystole in a previous lecture, but today we are going to deal with those extrasystole little bit more detailed explanation. Again, same, you will see only what you look for, you will recognize only what you know, and you will remember only what you understand. So I'll try to make it as simple as possible. So today's topic is extrasystole. Again, same. When you see more and more ECG, you will be able to identify those extrasystole, whether it is ventricular, whether it is atrial, whether it is nodal, etc. So you require to see more and more ECG and listen to more and more person. Now, meaning of ectopic beat, or we call extrasystole, means heartbeats occurring as a result of an impulse originating from the area other than SA node, or we call sinoatrial node. These ectopic beats are premature, or we call early, and they are not routine times at regular interval. So they are extra. That's why they are called extra, and they give rise to ventricular contraction. Hence, they are called extrasystole, or we call as early premature beat. If it is from atrial focus, we call as an atrial premature beat, and if it is from a ventricular focus, we call as a ventricular premature beat. So depending upon the focus, we call as an ectopic focus, which is other than SA node. If it is coming above the ventricle we have got two focus, one atrial and second is from the AV node. So we call atrial premature beat or premature atrial contraction. And if it is coming from AV node, we call AV nodal premature beat or junctional premature beat or nodal premature beat. And both these together, you can call that as a supraventricular premature beat. But if it is coming from ventricle, then we call as a ventricular premature beat or ventricular premature contraction. These are all the terminology I have shown you this slide before. You can call as a premature beat, premature contraction, premature systole, premature depolarization. You can call as an extrasystole or ectopic beat, and depending upon the origin, atrial, AV nodal or ventricular. And the commonest are atrial, so we call premature atrial contraction or atrial premature beat, and when it is coming from a ventricular focus, we call it a premature ventricular contraction or ventricular premature beat. This slide also I have shown you before, but I am repeating again, so just pay attention. So any extrasystole or ectopic beats, we call them as extrasystole, ectopic beats or premature contraction. You can have atrial extrasystole, nodal, we also call as a junctional extrasystole, or coming from ventricular extrasystole. Now in atrial and nodal, because it is coming from atrium, there will be a P wave. But as it is not coming from SA node, the conduction is not from SA node to right atrium and then to left atrium. It may be originating from left atrium or it may be originating from right atrium, but the area is different. Hence, the P wave configuration is abnormal. It is not a normal pattern. So it is a characteristic of an atrial extrasystole. This P wave will be followed by a normal QRS complex, because that impulse from the atrial ectopic focus will be transmitted to AV node, from AV node to bundle of His, then to right bundle, left bundle, and it will activate the ventricle. So that will produce a normal QRS complex. So it is a characteristic that you will have a normal QRS complex preceded by a P wave which is abnormal. And one another thing, as this bit comes early, so RR interval from the previous bit is less. That's why we call that as a premature or early extrasystole. And it is followed by a pause, which is usually non-compensatory pause. So it is less than 2 RR. Hence, this is called as a partial compensatory pause or non-compensatory pause. And this is a characteristic of an atrial extrasystole. Now, during this atrial extrasystole, as you get a P wave, that is activation of the atrium. So you get an atrial systole, and because of atrial systole, the blood is pumped into the ventricles. So LA will push blood into LV. So LV will have a good quantity of a blood volume, and because of normal QRS complex, there will be an LV systole, and this LV systole will have an adequate cardiac output, which will produce pulse. But the pulse volume will be little less because it is in a diastolic period of a previous beat. Hence, you will have a normal pulse followed by a premature beat, which will be of a low volume in case of an atrial extrasystole, followed by a pause, and then because the ventricle filling is very good, the next pulse will be of a good volume. This is a characteristic of an atrial extrasystole. While in a nodal, as the impulse is coming from AV node, it is in a right atrium, so it may activate and generate a P wave. The P wave is usually absent because it is overlapped by QRS complex, because simultaneous activation of a atrium and simultaneous activation of a ventricle will produce overlapping of a P wave over QRS complex, or you get immediately after QRS complex. So P wave will occur after QRS complex. Hence, the ventricle does not fill up as good as in an atrial extrasystole. But ventricle has got little amount of a blood, and this QRS complex has got a normal transmission from a AV node to bundle of his and then to the ventricle. So it produces a ventricular systole. So you got a apex, but pulse may be of a very low volume, and this QRS complex is followed by a pause again, which is non-compensatory. It is not a complete compensatory pause. In both this condition, you got apex, you got pulse. The pulse, because of an extrasystole, is early, followed by a pause. Hence, you will not have an apex pulse deficit. So in case of an atrial extrasystole and nodal extrasystole, you don't have a apex pulse deficit. You have got P wave followed by QRS complex, or P wave is just along with QRS complex. Hence, there is no missed beats. While in case of a ventricular extrasystole, there is no activation of the atrium. Ventricle is activated, it produces a wide QRS complex, which is premature, which comes on T wave or after T wave, which is a ventricular diastolic period. Ventricle is not filled up. As there is no contraction of atrium, there is no good filling of the ventricle. So ventricle contracts without complete filling. So cardiac output is almost nil. Hence there is no pulse. But as the ventricle is contracted, there is an apex. This will give rise to apex but no pulse. That's why we call it the apex pulse deficit. So in a ventricular extrasystole, clinically, while examining the pulse and apex simultaneously, you can make out because of apex pulse deficit. This wide QRS complex is followed by an inverted T wave, and there is a full compensatory pause. This is the difference between a ventricular extrasystole and atrial extrasystole. Again repeating, in an atrial extrasystole, you get a P wave before QRS complex, but P wave is abnormal. While in case of a junctional extrasystole, QRS complex is normal, and there is no P wave before QRS complex, or there is a P wave just after QRS complex, or it is just immediately before QRS complex. Hence, you will have apex as well as pulse. Pulse will be with a low volume, and there will be no apex pulse deficit in an atrial extrasystole and nodal extrasystole. This is how you try to differentiate clinically as well as on ECG. Now this is that particular slide which I have already explained you, that this is the normal sinus beat. This is a second normal sinus beat. This is third normal sinus beat. This is one cycle from here till here, and this is second cycle from one P wave to next P wave. So this is one cycle, this is second cycle. Here you will have a pulse and apex. Here you will have a pulse and apex. Here also you will have a pulse and apex. While in case of a ventricular premature beat, here you will have a pulse. This does not have a cardiac output, so there is no pulse, but apex will be there. So this will create apex pulse deficit, followed by a full compensatory pause, and then you got a normal sinus beat, which will produce apex, but this will be with a good volume. So here, this will be normal pulse, no pulse, and this will be with a pulse with a large volume. This is characteristic of a ventricular premature beat, and you will get an apex pulse deficit. While in case of an atrial premature beat, normal pulse, you will have a pulse here because there is an QRS complex which is a good contraction, and there is a little filling of the QRS complex. There is a little filling of a ventricle because there is a small P wave here, and that will give rise to an atrial systole, and so there is a little amount of ventricular filling. So this will be with a low volume, followed by a compensatory pause. We call it a non-compensatory pause or partial compensatory pause, and the ventricular contraction comes little early, next ventricular contraction, and it is with a good volume. Hence, this is called as a non-compensatory pause. This is characteristic of what we call as an atrial premature beat. You can understand this particular nicely. Now you can see here, from here to here, this is one RR. This was second R was supposed to come here, but it has come early, that's why we call it a premature. This is a broad QRS complex, followed by a opposite direction T wave. And you can see that there is no P wave at all. So this is a ventricular beat. As it has come early, we call it a premature. So this is premature ventricular beat, premature ventricular contraction, or we call ventricular premature beat. And you can see that next beat comes after a pause, and this is called a full compensatory pause because it has come exactly at the RR interval gap. And so this is a full compensatory pause. And then another R has come here, and this is equal to the previous RR. And again there is a ventricular premature beat. Both these beats are of the same configuration, so they are coming from the same focus. So we call as a unifocal ventricular premature beat. This is unifocal. So again repeating, in a premature ventricular contraction there is a complete pause, while in a atrial premature beat there is an incomplete pause. This is characteristic. This is again explaining the same thing. You can see these previous bits. There is a P wave QRS complex, P wave QRS complex, P wave QRS complex. Now here, the QRS complex should have come here, somewhere here. But this has come early. It is broad. T wave is in opposite direction of a QRS. QRS is negative here. This is T wave is upright. And there is no P wave preceding this QRS complex. Hence, this is a ventricular beat. It has come premature. So this is a premature ventricular contraction, or we call premature ventricular beat. Ventricular premature beat. And followed by a pause. We call as a full compensatory pause. Now, depending upon this coupling interval, if coupling interval is variable, then it becomes a multifocal or multiform ventricular premature beat. So during that time, during this period, pulse is not palpable. You don't get a pulse. We call that as a missed beat. That is a missed beat. So what I have explained to you before, this is a ventricular ectopic beat. What happens? You get a missed beats, or we call it the drop beats, and there is a full compensatory pause. And as the ventricle was empty, there is no pulse, but apex is there because there is a ventricular contraction, and this is called apex pulse deficit. And person will complain of a miss or a thumping beat or an extra beat, and person will have a sign of irregular pulse. And when you take a pulse, you will have a missed beat, and when you examine the chest, you will get apex pulse deficit, And when you examine the JVP, you will have a post-ectopic beat bouncing, or we call as a Canon JVP, because there is a contraction of a atrium and ventricle with a large volume that gives rise to little big wave we call as a Canon wave. This is a characteristic. This is a nodal ectopic beat or an atrial ectopic beat. What happens, I've already explained you that there is no base beat because pulse is there, hence there is no apex pulse deficit, and ectopic beat is followed by a compensatory pause, which is a partial compensatory pause, and ventricle is got more time for filling, and there was an atrial contraction, so that gives rise to a filling of a ventricle. But person will have an extra beat, irregular beats, and because of that, on examination, you will get an irregular pulse. There will be no base beat, but beat will come early. There will be no apex pulse deficit, and the beat which follows the ectopic beat is a bouncing, and it is of a large volume. And that gives rise to what we call as classical. This is we call in a supraventricular premature beat or a premature atrial contraction or a nodal premature beat, there is no apex pulse deficit. While in a case of ventricular premature beat, there is an apex pulse deficit because that extra beat does not give rise to pulse. Now we'll be going through some of those. We classify into three groups: atrial, nodal, or another name for nodal is junctional, or we call AV nodal, and we call ventricular premature beats. So now we'll have a few ECG which will show you that supraventricular premature beat, or we call atrial ectopics, atrial premature beats, which are very common, while nodal are very rare. They are very common in healthy people. We usually call that as idiopathic. It may be seen along with anxiety. The person who is taking excessive tea, coffee, or tobacco, chain smokers, ischemic heart disease, and valvular heart disease. Usually they are non-pathogenic, but when they come in large number, they can produce supraventricular tachycardias because of re-entry phenomena. And these two conditions you should pay an attention in a case of ischemic heart disease and valvular heart disease. You can see this is a normal sinus rhythm. There is no ectopic beat. Now we'll show you now you can see here there is an ectopic beat. This is a premature. You can see this is RR interval. This should have come somewhere here. It does not come at that time. It comes little early. There is a P wave. So this is an atrial premature beat. And because there is an atrial contraction, you will have a pulse. So this will be with a little less volume, followed by a compensatory pause, and this pulse will be of a good volume. And as this produces apex as well as pulse, there is no apex pulse deficit. And this is a characteristic of an atrial premature beat. Now you can see in a second ECG. So this is premature, abnormal P wave. That's why we call it atrial. And there is a QRS complex is narrow and normal, which gives rise to normal ventricular contraction. And there is a compensatory pause. Now you can see in this particular, there is a premature, but this is little wide. That does not mean it is a ventricular. There is a P wave here, and there is a wide QRS complex. This is because of aberrant conduction. Otherwise, all the characteristics remains like premature atrial contraction. You will have a pulse. You will have apex. Pulse will be there. Apex will be there, followed by a partial compensatory pause or a non-compensatory pause. And this bit will be with a little large volume. And in a JVP, you will get a Canon wave. This is a characteristic of a premature atrial contraction. Now you can see here also, there is a atrial premature beat, which has come little P wave, followed by a broad QRS complex, T wave in opposite direction. This is not ventricular premature beat. It is because of an aberrant conduction we call as a RBBB pattern. This is an RBBB pattern because this is a V1 lead. This is showing you RS dash pattern. So this is an RBBB pattern because of an aberrant conduction of an atrial premature beat. Same characteristics. There will be a pulse. There will be apex beat. No apex pulse deficit. Partial compensatory pause. And this beat will be with a good volume. This beat will be with a good volume. Now you can see here, there is an atrial contraction, but alternate contraction, normal followed by an premature beat. normal followed by a premature beat, normal followed by a premature beat. So we'll have a good volume pulse followed by a low volume pulse, then a pause, again a good volume followed by a low volume pulse and a pause. So this will be alternating good volume, low volume pulse, and then there is a pause. This is typical of alternating atrial premature beat. We call it atrial bigeminy. This is not a very common condition which will come across, but once in a while you can see this in case of a hypokalemia and in case of a digoxin toxicity. You can have this particular type of manifestation. And if it comes every third beat, then we'll call as atrial trigeminy. If two beats comes in succession, we'll call as atrial couplets. And if three atrial premature beat comes together, then we'll call as atrial triplets. And if it is same QRS complex, you can see these are of same QRS complex. They are coming from the same focus. They are coming from the same focus. So it is called atrial unifocal premature beat. These are the terminology. But if you come across of a different focus, so P wave is different at each time. Now you can see here the P wave is different. This is P wave. See this P wave. See this P wave. See this P wave. So if this P wave are different, then we'll call that as a multifocal. But if they are same, this looks nearly same. If you see this, these are nearly same. So this is unifocal. Now we come to ventricular premature beat. We'll be discussing again in detail in a ventricular rhythm separately. But here I'll give a little idea that ventricular premature beats are very common, normal. We call idiopathic because of excessive tea, coffee and alcohol. Very common in acute myocardial infarction, ischemic heart disease, myocarditis, digitalis toxicity, hypokalemia, mitral valve prolapse, cardiomyopathy, etc. These are all the conditions, out of which these two are most dangerous one because an acute myocardial infarction, ischemic heart disease, and in case of a digitalis toxicity. Do keep it in mind. They can end up with a ventricular tachycardia, ventricular fibrillation, and later on ventricular standstill. So you must pay attention. Now this is, you can see this normal QRS complex, normal QRS complex, normal, and then suddenly you got a broad QRS complex. And see this RR interval, it is less than this, so it has come premature. And before that there is no P wave. There is no P wave at all. So this is a broad QRS complex with inverted T wave in opposite direction. So this is a ventricular premature beat. So during this ventricular premature beat, there is no filling of the ventricle properly, and ventricle contracts before filling, because this is a ventricular diastolic period of a previous beat. So it has not filled up completely. There is no atrial kick. Hence this has not filled up. So there is no cardiac output. Almost there is a zero cardiac output. Hence there is no pulse. But this contraction gives rise to contraction of a ventricle. Hence there is an apex. But peripherally there is no pulse. So this gives rise to apex pulse deficit, followed by a full compensatory pulse. And now during this particular period, as there is a good diastolic period, the ventricle is filled up and this will produce a large volume pulse. So normal pulse, miss beat, followed by a large volume pulse, characteristic of a unifocal premature beat. And as it has come from ventricle, we call it a unifocal premature ventricular contraction. You can see, and both are of a same shape. That's why we call it a unifocal. They are coming from a single focus. Now you can see this premature beat and this premature beat. Both are ventricle, but they are of different shape. So they have come from a two different foci, ectopic foci. Hence, this is called multifocal premature ventricular contraction. Now you can see here, there are two premature beats. Both look almost identical. So this is called coupled ventricular premature beat. So this will produce normal beat, miss beats, a very long compensatory pause, followed by a good volume pulse. And this on an ECG you will make out two ventricular premature beat coming in succession. So we call it a coupled premature beat. Now here there are three beats together. We call ventricular triplets. So three ventricular complex which are abnormal. They are broad, no P wave, T wave in opposite direction. So you can see clearly these are couplets 1, 2 and 3. This is we call triplets. This is a broad QRS complex, T wave in opposite direction, and there is no P wave preceding. So all these three bits will be a miss bits. And on an ECG you can see this as a broad QRS complex with T wave in opposite direction, not preceded by a P wave. Here you can see a 4 bits together. When it is more than 3 bits in succession, we call salvos, or it is also called as ventricular tachycardia, because the rate wise this is more than 100 per minute. So we call it a ventricular tachycardia, but as it is not sustained, we call it a non-sustained ventricular tachycardia. But for non-sustained ventricular tachycardia, it should be less than 30 seconds, but more than 3 to 4 beats per minute. So usual word utilized is salvos. Again, there is a triplet here. This can end up with sustained ventricular tachycardia, ventricular fibrillation, and can end up with ventricular standstill. So you must recognize as early as possible. Again, this is a couplets. You can see very clearly a couplets which can be seen in a pair. This is triplets, 3 ventricular contraction. You can see clearly 3 ventricular, so we call triplets. Here you can see a single followed by a couplets, again single. Now this is triplets. Then again there is a single, again there is a single. But if you see, all these QRS complex are of a different shapes. You can see this is different, this is different, this is different. This is also of a different shape. So this is multifocal ventricular premature beat, having couplets, triplets, and patient is also having a prolonged QT. This particular group of people are more likely to develop torsada pointis and go into ventricular tachycardia, which is multiform or polymorphic ventricular tachycardia, and can end up with ventricular fibrillation and ventricular standstill. This is triplets. Now you can see here a normal beat followed by a ventricular premature beat, normal ventricular premature beat, normal ventricular, means alternating. That's why this is called ventricular bigeminy. Ventricular bigeminy. Here every third beat is ventricular premature beat, normal, second normal, third abnormal, normal, normal, abnormal. So every third beat, so ventricular trigeminy. Every third beat is abnormal. Now here every fourth beat is abnormal. You can see here. Every fourth beat is abnormal. So ventricular quadrigeminy, or we call tetrageminy. Quadrigeminy or tetrageminy. Here every fifth beat is abnormal. You can see every fifth beat is abnormal. And it is showing you what we call as a R on T phenomena. This is, you can see here clearly T wave, and after a little interval there is a ventricular premature beat. This is a fourth beat which is premature. So this is ventricular tetrageminy or quadrigeminy. But here it is fifth beat which is coming premature. And you can see here this is end of the T wave, and there is a QRS complex. This is called R on T phenomena. Whenever you get such QRS complex, this can end up with polymorphic ventricular tachycardia, and it is quite characteristic in a torsada pointis. So whenever a person is getting R on T phenomena, it is a dangerous sign. It should be treated as early as possible. So this is quadrigeminy and multifocal. You can see this is in one direction. This is absolutely different. So it is multifocal. and this is R on T phenomena. Again, you can see here every fifth bit is ventricular premature bit. So this is called ventricular pentagemini. Here initially it is bigemini every second bit. So this is run of bigemini, and then you will have triplets, and this is couplets. So this is pentagemini, this is couplets, this is bigemini run, and this is triplets. And it is different focus, so there are multiple ventricular premature bits. Now if you see here, this is RR interval, this is RR interval, this RR interval and this RR interval is constant. This RR interval is also constant. You will be able to see much better here. See this QRS complex, see this QRS complex. This is broad, there is no P wave, and T wave is in opposite direction. So this is a ventricular premature bit. There is no compensatory pause. And as there is a no compensatory pause, this RR interval has remained constant. So this is sandwiched in between the two normal sinus bit. And that's why this is called interpolated ventricular premature bit. Again repeating, RR interval here has remained constant. So even if this pulse doesn't come, you will not have irregularity, and this will not clinically, you will not be able to identify, because there will be a miss bit, but miss bit you will be able to calculate only if you correlate with apical impulse, but peripheral pulse will look regular, and this is typical of interpolated ventricular premature bit. Because there is no compensatory pause, there is no gap from this R to this R. So this RR interval is constant, and this RR interval is same as this RR intervals. And this does not produce pulse, but there will be apex. So when you compare apex with pulse, you will be able to identify apex pulse deficit. But otherwise, on a plain simple ECG, you can say interpolated VP bits. But when you take pulse without comparing with an apex, you will find that pulse is regular. This is characteristic of an interpolated ventricular premature bit. This is again a diagram showing you the same thing, interpolated ventricular premature bit. What are dangerous ventricular premature bit? R on T phenomena, multiple ventricular premature bit if it is along with acute myocardial infarction, multiple and multifocal ventricular premature bit. If it is more than 30% of the bits are multiple, triplets or salvos, or if there is a run which is non-sustained VT, you must treat them. This is R on T phenomena, which we have already explained you before. You can see here R on T phenomena ends up with polymorphic ventricular tachycardia. It will end up with ventricular tachycardia, and then it can end into ventricular fibrillation also. Now as far as the junctional premature bit is concerned, I have already told you the junctional complexes. There is no P wave before. You will have a narrow QRS complex, and if you have got a P wave, it may be just before QRS or just after QRS complex, and the rate will be between 40 to 60 per minute. So there will be no P wave. As there is no P wave, no PR interval. If at all if P wave is present, usually it is inside the QRS complex, or maybe after QRS complex, or maybe just before QRS complex. Hence you will not be able to identify the PR interval. QRS complex is narrow, there is no pacemaker spike, and the rate is usually between 40 to 60. If rate is between 60 to 100, we call it an accelerated junctional rhythm. If the rate is more than 100, junctional tachycardia. And if rate is less than 40, we call it a junctional rhythm with slow ventricular rate. These are the words which are being utilized. I'll show you one ECG which will show you those particular things. Here you can see this is a normal junctional rhythm, no P wave, QRS complex. Hence this is more in favor of a junctional rhythm. And if you calculate the rate, this is between 40 to 60, that is approximately 50. So this is normal junctional rhythm, no P wave. Now if you see here, in this P wave is preceding QRS complex, hardly you can see a PR interval. Now this P wave is inverted, followed by a narrow QRS complex. Now if you see in this, QRS complex is followed by a small P wave, inverted P wave. And this P wave is inverted. It is not a normal upright QRS complex direction. So in a normal person, in a normal sinus rhythm, P wave is upright in a direction of a QRS complex. And if you see in a third one, there is no P wave at all. So here the P wave is merged with a QRS complex. Here the P wave is after QRS complex by retrograde transmission, and here the P wave is inverted, which is just before the QRS complex. Here again you can see that there is no P wave at all. So no P wave. Here P wave is before QRS complex but inverted. Here also P wave is there but inverted and after QRS complex. This is junctional rhythm. Now you can see here, this is normal sinus, normal sinus, normal sinus, and this has come little early. So it is premature. The QRS complex is narrow. So it is either from atrium or from junction. And as it has come early, so this is premature. It has come from AV node. So it is junctional beat. So it is called junctional premature beat, or we call premature junctional conduction. We call PJC. So this is a characteristic, and during this time you will have a pulse, you will have apex, and there will be no apex pulse deficit, and there is a full compensatory pause. You can see there is an compensatory pause. Here also similar thing, you can see no P wave, same identical QRS complex, and T wave is in the same direction, a narrow QRS complex, a narrow QRS complex, and that is premature junctional contraction or premature junctional conduction. Again you can see here, this pointed out, this is a premature, there is no P wave, so this is a nodal premature extrasystole, or we call junctional extrasystole. Here I end my lecture. I hope this will be helpful to you.